We'll just start the recording. Kindly just confirm if my screen is visible.
Confirmed, go ahead.
Okay. Good evening, everyone, and welcome to this session. It's going to be the first of a series facilitated by Dr. Adil Waris. My name is Felix Mburu. I am a fifth-year medical student, currently doing pediatrics. So we'll begin. So the objectives for today will be to define a few terms related to pediatric pneumonia, to look at the epidemiology, the etiology and pathogenesis of pneumonia, diagnosis and classification, management, as well as prevention strategies at the end. So definition of terms. So pneumonia is refers to the inflammation of the lung parenchyma that's usually due to infection. And another term that's often used in an interchangeable manner is a lower respiratory tract infection. But this is a larger, broader term that encompasses bronchitis, bronchiolitis, as well as pneumonia, or any combination of the three. So, as you can see, this is just an illustration of what pneumonia is. It's an inflammation. It's inflammation within the lung parenchyma, and this will lead to these air spaces being filled up with fluid. Um,
And I think the point also here, Felix, is to understand that pneumonia is a parenchymal infection. So it's the alveolar spaces, the interstitium that is infected by this bacteria, and that it's not the pipes that go down to the lung parenchyma. So bronchiolitis, bronchitis, as you have clearly mentioned, those are diseases of the pipes. And why this distinction becomes important is in clinical assessment of these children, because in pneumonia, you will have children with either crackles or bronchial breath sounds, because that's the part that's being affected. And in children who have bronchitis, bronchiolitis, we'll be talking about wheeze, which is not present 99% of the time in pneumonia. And I think that's the only thing that I feel is very, very important for all of us as colleagues, which is that by the time you're hearing a child wheezing, we need to understand that the level of affection, infection, obstruction is at the level of the trachea, bronchi, bronchioles, peripheral bronchioles, and not at the level of the lung parenchyma. Infections at the lung parenchyma do not give you a wheeze. And that is the single most important take-home message on this particular slide. Felix?
Thank you. So on to the next slide. So pneumonia is the leading killer of children under 5 globally. We had the child health seminar last week, and we looked at various causes, and pneumonia was the leading, alongside others like diarrhea, um, birth-related and neonatal issues, among others like malaria. And about 150 million new cases of there are about 150 million new cases of pneumonia each year, and over 725,000 children under 5 die each year from pneumonia, which emphasizes the importance of this condition in the pediatric population. And according to the Kenya Demographic Health Survey done in 2022, the percentage of children with symptoms of acute respiratory infection was 1.7%, which translated to close to 17,000 children. And that was a survey where they would ask the guardians if the children had symptoms of acute respiratory infection in the last 2 weeks, and that is what will meet the criteria for the data they were collecting. And about 18% of the cases had not sought advice for any treatment. And the leading county with in terms of the percentage of children with acute respiratory symptoms of acute respiratory infection was Homa Bay County. And just to emphasize that, and we look at this at the end, is that there are effective and cost-effective interventions to end preventable childhood deaths from pneumonia, but the coverage is low, particularly still in our setting, it's still a bit low and needs to be addressed. Dr. Waris?
Carry on. I'll interrupt you whenever I need to.
Okay, so in terms of the pathogenesis of pneumonia, so there are two key factors that come to play in the pathogenesis of this condition. Number one is the impairment of the host's defense, and number two is a virulent organism being present and invading the lung parenchyma. So those two are the key factors: an impaired defense and invasion by a virulent organism. And typically, it will start with an upper respiratory tract infection, which will progress to and affect the lower respiratory tract. Then it will end up triggering an immune response and inflammatory process, which leads to the air spaces being filled up with white blood cells, fluid, and debris, which subsequently reduces the compliance of the lungs, increases resistance, and obstructs the smaller airways. And this will lead to collapse in the distal air spaces, leading to air trapping and unaltered ventilation perfusion. So there'll be a mismatch in the VQ, and that will now also lead to the symptoms, such as hypoxemia, and that we'll also look at. And if severe, you can have necrosis of the epithelium and also lung parenchyma.
So, colleagues, this virulent organism that we are talking about, that Felix is alluding to, is for us to understand that 99% of the time, it's going to be triggered by a virus. All of us have suffered from a common cold. So we know that we get coryza, we get a runny nose, watery eyes, etc. And then the throat infection, the viral throat infection goes away. But every so often, this severe upper airway viremia now moves down into the lower airways, especially in immunocompromised hosts. So that is Felix's impairment of the host defenses. That's what's meant at that particular level. And colleagues, what I think is also important is for us to understand that both the upper airway and the lower airways have microbiota that is living, symbiotically within our bodies. So our lower airways, previously we thought to be sterile below the larynx, is no longer the truth. Below the larynx lies a happy host community, rather, of viruses that are just sitting there and bacteria. So when you get a virus that then decides to go into the lower airways and disrupts that happy situation, that leads to now the invasion of the lower airways and of the lung parenchyma with a virulent bacteria that starts overpopulating. And so that point is very important, that usually it's triggered by a virus. Felix, next slide.
So in terms of acquisition of these organisms, so most often it's transmitted by droplets from a close contact. It could be the caregiver or other children. And but fomites may also be an important source, especially in RSV. And for bacterial pneumonias, the initial colonization of the nasopharynx is followed by aspiration or inhalation of the organisms. And the invasive disease is often upon acquisition of a new serotype, is usually often after you have a new serotype that the patient had not encountered previously. So it's for you to have the disease that progresses the most, it's typically a new type or a serotype that the host has not encountered and is therefore not immune to. And the incubation period is typically 1 to 3 days. And it's not always that you will have pneumonia, then progressing to bacteremia. You can actually have primary bacteremia preceding pneumonia. And atypical pathogens may attach to the respiratory epithelium and also enter. For some of those organisms that we learned about, I think in microbiology, such as mycoplasmas are usually intracellular, and so these ones invade a bit differently since they require to replicate in an intracellular environment. So they attach and then replicate within the cells of the respiratory epithelium.
And so your second last bullet, Felix, is really more of adult pulmonology. So that's when you may have a primary bacteria, usually, but in pediatrics, remember, it'll mostly be viremia. And the last bullet is why you'll also see that these atypical pathogens like chlamydia and mycoplasma give you more of a bronchitis rather than a full-blooded lower respiratory tract infection causing pneumonia and hypoxemia. That's not meant to say that mycoplasma cannot give you a pneumonia that gives you hypoxemia, but usually it causes a bronchitis. And I like this point that you've made, that it goes for the respiratory epithelium and kind of remains at that level. Felix?
So just back to the host defenses, just to emphasize that we mentioned that there are two key bits when it comes to the pathogenesis of pneumonia: an impaired host defense and the presence of an invasive organism. So these host defenses that we talk about are you can talk about immediate, early, and late, and under immediate, you have the physical barriers. So it's just anatomic and physiological barriers. So such as the nares, the glottis, and then you have tight junctions in the epithelium. You have the cough reflex, the mucociliary escalator. Yes, so and the secretions, such as mucus, the hair that you have in the respiratory, um, uh, in the nose and all. So those are the physical barriers, which are the immediate barriers. And so even when they are breached, it now leaves you at higher risk of getting pneumonia. And then the early host defense comprises of the innate immunity. So the innate branch of the immunity. Um, so here under this, you have airways surface liquid, okay, which can also count under the physical barriers, but then you also have macrophages, you have mast cells, you have the activation of the complement system, and this will form the early host defense. And when it comes to late, which now kicks in later, maybe 3 days or 4, here you have the adaptive immunity. So you'll have a recruitment of um, neutrophil recruitment and activation, as well as lymphocytes being activated to the site of the infection.
And Felix, at this particular point, if you look at the place where you say cough, and you see cough is actually a pulmonary defense, host defense, and this is probably a reason why we are trying to also avoid cough mixtures like antitussives, for example. I know that the parent out there will come to you and I in the casualties and say, "Oh my God, my child is coughing so much." But to give the antitussive is to actually take away what is actually a protective mechanism to prevent this child who's got a viral URTI from getting a bacterial LRTI. And all of us who are listening right now know that you don't want to get a bacterial LRTI. So that's the usefulness of that. And then also, when you look at the early and the late, it's also for us as clinicians to be aware that in pediatrics, if you get a child who's presenting in the first month and the third month and the fifth month with pneumonia, that there's a possibility that these early factors and late factors our colleague is talking about might be compromised. And so you need to look for, like if there's a problem with the ciliary airway, then you're thinking about primary ciliary dyskinesia. If you're looking at macrophage dysfunction, then you're going to get rare diseases causing chronic granulomatous diseases that are not necessarily tuberculous, etc., etc. So a lot of these things will then also determine how you investigate. So if you get a child who is 4 years of age presenting with the first pneumonia, it would be very unreasonable to then start looking for primary immunodeficiencies because that shouldn't affect a 4-year-old. But if you have a 4 or a 5-month old with the first pneumonia, then these are some of the things that you need to look at and consider investigation, especially if it is an atypical um, microbe or if it is coming in very severe, etc. Felix?
So the purpose of this slide is also just to reemphasize what Dr. Waris had mentioned about nasopharyngeal microbiome. I know we learned about microbiome, particularly in the context of the GIT, and that's why we learned that we have good bacteria and bad bacteria, and the balance is very, very important to maintain. And initially, even I think as when you were taught, we were taught that the lower respiratory tract is a sterile environment without any microbiomes, but there are actually some microbiome, but low biomass. And just like in the gut, that balance is very important. And whenever you have a disruption in that balance, dysbiosis, it now predisposes you to getting pneumonia and lung conditions, and factors that may lead to alteration in that microbiome can be things like crowding, pollution, etc. And so you have, as you can see in the green box here, you have the good, healthy nasopharyngeal microbiome, such as Moraxella, Staphylococcus, etc. And in when you have the respiratory tract infection, this is affected, and you have reduced diversity, and you have some these specific organisms such as Haemophilus, Streptococcus, and Neisseria, and oral type anaerobes proliferating and colonizing, as well as also you can have respiratory viruses such as influenza virus and RSV. And the oropharynx, you also have various bacteria which are there when so that you have higher diversity, but then in infections, that diversity is disrupted, and now in the lower respiratory tract from now the larynx going down now in the lungs, typically you have low biomass. You have organisms such as Prevotella, Veillonella, Streptococcus, and in infections, when this balance is disrupted, you have high biomass, and you have some of these organisms now also colonizing the lung and leading to infection. This is the reference for the paper for anyone who'd like to go and have a look at it.
I would like a colleague, and I really don't want to pick a name from the list, and it's not a witch hunt, colleagues. I'd like you to unmute yourself if that is possible. Kavisha, is that possible for anyone to unmute themselves?
Yes, they can unmute.
Okay, fine. Anyone who's willing to suggest to me that if I was a smoker, how that would affect my upper and lower airway microbiota, and if I was a smoker, how that would affect my children's upper and lower airway microbiota. Apart from Felix and Kavisha, anyone would like to try?
I think, hello. I
Yes.
think I can try. I think smoking, be it passive smoking or active smoking, will affect the microbiota in terms of smoke, the gases inhaled, which contain chemicals, will affect the normal surrounding of the microbiota in the lower respiratory tract. Yes. So I
Innocent,
think
I'm so happy you're volunteering, but I'm pushing the agenda. Why? You have made a statement. Smoking, passive or active, is going to change my upper and lower airway microbiota. I agree with you. But explain to me why so that I remember it for the rest of my life. Why?
I think the chemicals in smoking,
Yes.
yes, will kind of let's say kill or affect the microbiota.
Yes, use the word kill.
Yes.
Let's do this together, innocent. So, if you kill the good by microbiota in my upper and lower airway, what do you think is going to come?
The bad the bad
Yes, yes.
organisms.
So, if you kill the good, who's going to come, innocent? The bad.
The bad.
Now, if I have bad microbes in my upper and lower airways, and I'm kissing my children, I'm coughing in the environment, that kind of thing, what kind of colonization do you think my children's upper and lower airways are going to have?
The same. Yeah, it's kind of
Beautiful.
we are transmitting.
Thank
We are
you. And
transmitting the.
correct. And the bad microbiota, innocent, are more virulent and are going to be more penicillin resistant. Okay? So this is not just about smoking. It's about incense. It's about scented candles. It's about biomass fuels. It's about our beautiful Somali community that's burning oud and luban in the houses. So these are things that we need to try and avoid and share with various communities what they can and cannot do. Innocent, I'm so grateful to you because it's nice when we have uh, a team that is also answering. So thank you for stepping up. Felix, next slide.
So there are various pathological patterns of bacterial pneumonia and also viral pneumonia at the bottom, but bacterial pneumonia are the main ones. So you have a lobar pattern, which involves a single segment of the lobe. Remember, the lung was has a lobe, anatomical lobes, and this pattern is commonly seen in strep pneumo, and you also have a bronchopneumonia pattern where you have the primary involvement of the airways and the surrounding interstitium, and it's sometimes seen in strep pyogenes and Staph aureus pneumonia. Then you also have necrotizing pattern, which is associated with strep pneumo, pyogenes, and Staph aureus. And then you also have caseating granulomas, commonly seen in tuberculosis, in Mycobacterium tuberculosis, and also mycosis. And then you also have what is known as interstitial and peribronchiolar with secondary parenchymal infiltration. And this pattern typically occurs with viral pneumonia. And when viral pneumonia is complicated by bacterial pneumonia. So you can have viral, then but having viral pneumonia also predisposes you to getting bacterial pneumonia. And the pattern most seen in viral pneumonia is interstitial and parenchymal patterns of the pathology.
In this slide, I think the important thing for us as colleagues to remember is that in 5 to 7% of all children presenting to us with what looks like an acute lower respiratory tract infection, tuberculosis has been found in various meta-analysis. In fact, there's a colleague of ours, I don't know if you know her name, Dr. Jackie Oliwa, an amazingly impressive young colleague. And she showed, and it'll be useful to type in her name, Oliwa, Oliwa. She's done a lot of work in pneumonia and in tuberculosis pneumonia. When I was training in med school, etc., we were told that you can never get tuberculosis as an acute infection. So Felix's point number 4 is very important. They may not necessarily cause caseating granulomas, but to understand that you need to also be hunting for tuberculosis in an acute setting. Felix.
So this is just to re-emphasize. I won't belabor this point too much, but there are various pathophysiological effects of these infections. They'll damage the physical barriers, increase adherence, decrease the mucociliary activity, cause dysfunction of immune cells, and also upregulate toxins, gene expressions. And you can also have a mix of bacterial and viral uh, infection. And you have various complications of these infections. You can have empyema. It can also spread to other parts of the body, causing meningitis. You can have toxic shock. You can have sepsis. You can have lung abscesses, and ultimately, it can, like it, as you said, it's a killer, and it can lead to to death.
Carry on.
So, for the etiology of pneumonia, as I said, you can have bacterial, viral, and mycobacterial. And the point of having a Venn diagram is to show that you may have overlapping. So you may have coexistence of bacterial and viral. You may have viral and mycobacterial. You may have bacterial and mycobacterial. Um, and in immunodeficiency, you may have pneumocystis pneumonia, pneumocystis jirovecii, playing a bigger part, and also cytomegalovirus, which these are most commonly seen in people who are immunocompromised, children who are immunocompromised. And we'll also see that when it comes to management, particularly for pneumocystis pneumonia. And so for Bordetella pertussis, it's commonly seen in people who are unvaccinated, since this is part of the CAPI schedule. People who are children who are unvaccinated, and HIV exposed individuals.
Also, remember, dear colleagues, that when we're talking about bacterial, viral, mycobacterial, the studies is what's very hard to prove who is causing what. So, say tomorrow I'm a 5-year-old child and I come to you breathing fast. I mean, how can you prove what is the bacteria that's actually causing my pneumonia? If you decide to do a sputum and we grow bug A, we can turn around and say, okay, that's what's causing the infection to me, but it could also be what was the commensal that was in my airways, and that stands for the lower airways as well. So that is the difficulty in pulmonology. Whereas if I was to do urinalysis, you'd be able to tell what's growing in my bladder, because ideally nothing grows there. The problem now in the respiratory tract is very similar to that's in the stool. That, are you growing a pure culture of something, or is it a contaminant or a colonizer of that particular area? But we're doing the best we can. There's PCR testing on sputum samples now, but the point is still maintained that the sputum and the bronchiolar alveolar lavage fluid that I remove from a 5-year-old, is that what was just there before the pneumonia came in? Or is that the real disease that's causing the pneumonia? So this has always been a bit of a dilemma in pulmonology, but we do the best we can, and we are at that point right now. Felix, next slide.
So, on to the top 10 causes of pneumonia in Kenya. This is from a study that was done, multinational study, famously known as a patch study or trial, and patch stands for Pneumonia Etiology Research for Child Health, which was a multi-country case control study that was conducted in Kenya, among other countries, and it's a paper published in the Lancet, in fact, for a journal, infectious disease, and it was conducted in multiple countries, I think supported by Bill and Melinda Gates Foundation, and the purpose was to try and do and establish the etiology, the actual etiology of pneumonia in various countries, particularly in Africa and Asia, because majority of the existing data was Western and did not necessarily reflect the actual etiologies in various parts of the world, particularly Africa and Asia, where where there's always been paucity of data. And so what this showed in Kenya, and the study site was in Kilifi, it showed that the top 10 causes, the leading ones were viral, as was also emphasized. So the top cause was RSV, 36%. So you can just follow that pie chart as in a clockwise manner. So followed by rhinovirus, then HMPV, parainfluenza, H. influenzae, Haemophilus influenza, that's now a bacterial cause, strep pneumo, also bacterial, then influenza, the virus, then pneumocystis, Girovesci pneumonia, then Mycobacterium tuberculosis, you can see it at 1.9%, and you can see RSV was at 36%, and then Staphylococcus aureus at 1.3%. So those were the top 10 causes of pneumonia in Kenya.
So, colleagues, if you take a look at this and you compare it with data before this particular study, everyone was jumping up and down talking about strep pneumo, strep pneumo, strep pneumo. But as time has gone on, we are understanding that when the child comes to you age 0 to 5, 0 to 6 years of age, coughing, breathing fast, having a fever, having all the definitions of a WHO criteria for a lower respiratory tract infection, that your top 5 sellers are still viral in nature. I want us to focus on two things. I don't know if I'm going to speak prematurely, but with RSV, there's now studies out there and clinical trials looking at vaccination of pregnant women in the last trimester with 2 vaccines that has been shown to reduce the RSV burden by up to 66 to 70% in children aged 0 to 1 year of life. And that's one of the commonest causes of bronchiolitis and lower respiratory tract infections. So that's something to note because there's something in the pipeline, and we'll talk about it a little bit more if towards the end. The other thing that I want to put to your attention is just take a look at influenza 5%. Yet everyone is on this war path to give everyone on the planet an influenza jab. Could anyone in the team turn around and tell me what you think is the efficacy of the influenza vaccine? Can someone kindly, don't Google and chat GPT, people. Anyone, efficacy of the influenza vaccine? Come, people, I don't want to pick a name. Gloria Wemanye, what do you think? Efficacy of the influenza vaccine? Cindy Jaguero, unmute. Joanne, talk to me. It's terrible when you're in the first. I don't want innocent.
7%.
No, somebody else. Not you. Come on, people. Innocent is not the only person in your class.
Maybe 70%.
Stay with me. Who is this?
Cindy.
Cindy. Thank you. Thank you for being brave. Is 70% you reckon, Cindy?
Pardon?
You're saying 70%, huh?
Yeah.
I want you to stay with me. Don't unmute yourself. Cindy, the studies have shown that the efficacy of the influenza vaccine is anything between 10% and 55 to 60%, depending on the year that we are discussing. So think about this. The PERCH trial is saying that 5% of children hospitalized had influenza, and the efficacy of this vaccine can be anything between 10 and 66. Yet you and I wouldn't go for the COVID vaccine of 55 and 66% protection. We wanted the Pfizer, and I can't remember who, at 85 and 90. You remember those days, Cindy?
Yeah.
So if you're not willing to take a 66% efficacious vaccine, why would you take one that's probably between 10 and 60%? You get the thought flow process?
Yes.
And then you have to take it once a year, every year till death do we part. So I'm not saying don't give the influenza vaccine. I'm saying we need to strategize ourselves and use it for the children who have an impaired immunity, sickle cell, HIV, oncological disease processes, etc. Felix, next slide. Thanks, Cindy.
So just to look at the etiology in a different way, you can have various ways. So you can have of looking at acquiring pneumonia rather. So you can have community acquired pneumonia, which is most commonly viral. You can have aspirational pneumonia, and the thing you'll be aspirating is the oral flora, the anaerobic oral flora, and you can also have hospital-acquired pneumonia, and this is the pneumonia that comes about more than 48 hours after admission in hospital, and it's more often found to be gram-negative bacilli or also Staph aureus.
Also remember, Felix, that with point number 2, the anaerobic oral flora, also remember that the mouth also has aerobic oral flora that can be also aspirated into the lower airways. So it's just that anaerobics are so hard to culture in media that we just highlight it. But also remember that the mouth also has access to aerobic oral flora. Carry on.
So what are the risk factors for pneumonia? So you can look at them. You can have host characteristics as well as socioeconomic and environmental risk factors. But ultimately, it's either of the two things that we talked about. It's either a factor that will cause an impaired
Okay,
immune
stop there.
system. Okay.
Stop. I want any colleague, please don't let me pick up a name. I really don't like doing that. Can somebody tell me how prematurity is a risk factor? Come, the faster we do this, the better. We are not taking notes.
Their lungs are not developed.
Yeah,
well.
who is this? Give me your name.
Husseina.
Okay, talk,
Abdullah
Hussein.
Bhai.
Husseina, talk.
So when the baby is born before gestation, their lungs are not fully developed. So this can increase their chances of.
How? I want to know why. I want you to dig a bit deeper than that, Husseina. Your answer is correct, but how and why? Somebody else wants to try? Somebody wants to help Husseina? Come on, people. Go for it. Name? John. Okay, go for it, John.
Yeah. So during the gestation age, of 24 weeks to 34 weeks is the period where surfactant is produced. At 34 weeks is where it is like there's enough surfactant, and I think also during birth, if it is through when the baby is at term and given birth during that by spontaneous vertex delivery, I think at that time there's usually more production of surfactant, and I think it helps the baby when to have the lungs to be more compliant. Yeah.
So your point is that because the small baby has less surfactant, the alveoli and the terminal peripheral bronchioles will not be able to open and close, so there'll be a risk for agar formation and bacterial overgrowth, correct?
Yes.
So John, stay with me. We work together, you and I. Prem babies, do you think that they have strong white blood cells or not?
The term babies.
No, prem babies. We are talking prem. Take a guess, buddy. It's not complex.
Yes, I think these babies, preterm babies, they fail to. They have difficulty breastfeeding. I think
No.
so.
John.
And,
John.
Yeah.
They are white blood cells. Do you think they are strong?
Oh, they're white blood cells. I don't know. I'm not sure.
I want you to take a guess.
I think they aren't.
Thank you. You're correct. Do you think they have enough immunoglobulins as a term baby?
No.
Do you think that their airway clearances are going to be better?
Okay, maybe when they breastfeed,
No, you forget about breastfeeding now. We're talking about the baby who has just been born. Do you think that their airway clearances are better?
No.
Their vitamin Ds are going to be lower. Their thoracic cages are going to be weaker. Their lungs are going to be less compliant. They're going to have more bronchopulmonary dysplasia. You're getting the point.
Yes.
The prem babies are at higher risk of reflux, and reflux is a common cause of secondary lower respiratory tract pneumonias. Thanks for joining me, John. I think you've got the point, yeah?
Yes, thank you.
Yeah. Felix, carry on.
Thank you.
Move to infancy and beyond.
Yes, so infancy, again, for infants, their immune systems are not as well developed, so they are at risk. Lack of immunization, again, immunization is meant to protect, and by augmenting the capacity of the immune system to against specific organisms, and so failure to immunize children puts them at risk of the various causes of pneumonia.
Felix.
Yes.
I'm going to interrupt you. Leave everything on the left-hand side. At this stage in our lives, I think everyone understands on the left. Move to the right.
So in terms of socioeconomic and environmental, young maternal age is a risk factor. Low maternal education, low socioeconomic status, poor antenatal care, tobacco smoke exposure, indoor air pollution, as well as crowding.
Now, we discussed this in earlier slides, true? Felix, tell me why low socioeconomic status is a risk for future pneumonias.
So the low socioeconomic status will...
Actually, where is Kavita? Who is the lady who we have organized this with? Her name is Kavita.
Kavisha, yes, Kavisha.
Sorry. Kavisha, are you there, my dear?
Hi, Dr. Waris. I think she's experiencing some connectivity issues.
Who is you?
Oh, hello, my name is Dana Hope.
Diana, talk. Why does the low SES contribute to pneumonias?
So why does a low?
Low socioeconomic status.
So I'd say it's a contributing factor because of the level of hygiene is
Agreed.
Yeah.
So there's less hand washing, there's more likelihood that you'll have more bacterial overgrowth on the people's hands, etc. Next, you're doing well, carry on.
I'd also say a low socioeconomic status could also translate to their level of education, so they're not really aware what to do. Or
very good. Yes. They'll come to hospital later. They'll not understand that fast breathing is a warning sign. Excellent. What else?
Also, I would say low socioeconomic status means that they're also probably not able to afford healthcare. So they might then seek other cheaper methods. And then also the way they live, their homes might not be well aerated. There could be overcrowding. Yeah.
Now, Diana, I want you to stay with me on this slide. You know what? The secret is actually on this page that we're looking at. If you have low socioeconomic status, the chances of you being a hungry mother are higher. True? Diana?
Yes.
Yeah. And if you're hungry, my dear, you're going to give birth to a low birth weight baby, most likely premature. You're most likely going to lack immunization because you don't have the knowledge, or you're too far away from the health center, or you cannot afford the matatu ride. I'm on the left-hand side. You may not be clued in on exclusive breastfeeding. You may be starting to water down the milk that you're giving your child. More likelihood that your child is malnourished, higher possibilities of HIV, higher chances that the mother is young of age, has less education, has poor antenatal care, and has indoor smoking, etc. So have you noticed how all the answers are actually on this page?
Yes, I have.
So all of them, Diana, are intertwined with each other. Some idea.
Yes, thank you.
Thank you for contributing. Felix, next slide.
So now on to the clinical presentation of pneumonia in the pediatric population. So the presentation is non-specific. There is no single sign or symptom that is pathognomic for pneumonia in children. And these symptoms may present as fever, cough, tachypnea, signs of increased work of breathing, such as the grunting, lower chest wall in drawing, etc. And then in neonates and infants, you may also have difficulty in feeding, restlessness, and fuzziness. And slightly older children may also have pleuritic chest pain, abdominal pain, which is referred pain, and as well as nuchal rigidity.
Just remember that the chest pain might not be that obvious for children under 5 or 6. And that tends to happen to the children who are slightly older than that. And even the nuchal rigidity is only if you have a loba-like disease process in the apices, Felix, of the lungs rather than the bases. And most pediatric patients will have a bronchopneumonia, so don't look at the nuchal rigidity that seriously. And I think if you saw nuchal rigidity, I think your brain must just be focused on meningitis at that point in time, because that's been the more serious disease process. Next slide.
So diagnosis and classification of pneumonia, and so in children, so pneumonia can be classified as severe pneumonia, or which is non-severe pneumonia, and no pneumonia. And so the various parameters that are looked at. So in a child aged 2 to 59 months, so to 5 years, presence of cough or difficulty in breathing plus. So for oxygen saturations less than 90%, cyanosed, unable to drink, reduced level of consciousness, and grunting, particularly for infants, that and is classified as severe pneumonia. And then if the respiratory rate is above or equal to 50 in the age baby aged 2 to 11 months, or more than 40 in a baby aged child aged 12 to 59 months, and lower chest wall in drawing, that is classified as pneumonia or the non-severe pneumonia. Remember, lower chest wall in drawing is no longer maybe a danger sign. It's just, yeah, it's a bit lower. So, and then none of the above is classified as no pneumonia.
Carry on. And remember, dear colleagues, as Felix is going on, we had agreed at the beginning that if you post questions, we will answer as we go along. So you don't have to post the questions at the end. I hope that that is clear. So I'm really here to share with. So if you have more questions, we'll have more of a conversation. So please don't hesitate to post. Felix.
So now onto history and physical examination. So there are various aspects you'd want to try and elicit from the history. So the age, whether there was a recent upper respiratory tract infection, and then the symptoms, if there's associated headaches, sore throat, conjunctivitis, rash, photophobia, cough, chest pain, shortness of breath, difficulty in breathing, increased work of breathing, how the fluid and nutrition intake has been affected, choking episodes, and then characterizing all the symptoms in their duration, their character, And then if there have been previous episodes of similar related conditions, and then the various risk factors that we looked about that we mentioned. So just trying to check for all the risk factors that we mentioned, from immunization to contacts to the environment they stay at to the environment they are in, whether it's a daycare, whether it's at home, whether they're animals they spend time with, etc. And then also trying to find out if there are any complications that may have come about. Yeah, so because it can worsen, lead to sepsis, can lead to um, meningitis, etc., as well as a history of the treatment they've had up until that point of history taking.
I'd like somebody to share with us that if you look at the Felix's last bullet on treatment history, that I bring you a 3-year-old child and I turn around and I say that this child has taken amoxicillin in the outpatient setting and now comes in with a full-blooded pneumonia 3 to 5 days later. How would that adjust my treatment protocols? Anyone, please.
Hello.
Go ahead.
Yeah, I think if there is history of treatment with antibiotics, you may be worried about development of resistance to the antibiotics.
I agree. So if this patient was on amoxicillin, what would you do, Joshua?
Then I may want to move on to the next line of treatment, like ceftriaxone.
Okay, you may or you will?
I will.
Okay, fine. So that's the point, isn't it, colleagues? That if you've worked with an aminoglycoside, you can't really move to another aminoglycoside. If you've worked with crystalline penicillin somewhere and it is failing therapy and you're the first point of contact, you need to move to a higher level of antibiotic coverage. Thank you, Joshua. Felix?
So now on to physical examination. So you'll start with the general exam, look at the general appearance of the.
I want you to leave this entire slide and move to the second last bullet and move from there.
So
no. Go back. Yeah. Increase work of breathing. Explain how.
Yeah. So yes. So so physical exercise should try to look for increased work of breathing, looking for the various signs. Head nodding, grunting, low chest wall, in drawing, cyanosis, etc. And then you want to perform auscultation, so listening for crackles and bronchial breath sounds.
So colleagues, with the crackles, I think that one most of us are clear about, or we are getting used to that as we are listening. But bronchial breathing is where we sometimes make errors. So if you just auscultate over the trachea, it's as if you're hearing that sound almost straight in your ear. So that's the kind of sound that you're looking for. And tomorrow is a public holiday, otherwise I would have been in Kenyatta. But the following Thursday, when you guys are there, I don't know if you go on leave, we should look for more signs of bronchial breath sounds because that's important to diagnose lobar pneumonia. So please remember, if you get a bronchial breath sound, we are talking about that is a sign of a lobar pneumonia. So when you percuss on that area, it will be dull. And when you listen to that area, you will hear it as if it is a loud sound straight into your ear. And that will be lobar pneumonia. Felix?
So now on to radiological evaluation. So chest radiographs are not always necessary for the diagnosis of pneumonia, and they're usually just indicated for severe disease, for confirmation or exclusion of an inconclusive diagnosis, And then in the case of hospitalization, then history of recurrent pneumonia to assess complications and also to exclude pneumonia. And various caveats on factors to considerations that you need to have in mind when you're doing radiologic chest radiographs evaluation for pneumonia is that radiographs are poor indicators of etiology, and the findings on a radiograph may lag behind the clinical findings. So whatever you may be seeing, finding clinically may be quite severe, but what you find on the radiograph may not quite match what you're finding. And then intra-observer and inter-observer variation is a factor. So therefore history is key when it comes to the interpretation of any radiograph you may have.
Colleagues, I only have one more addition to make on Felix. Imagine all of you, God willing, qualify next year or the year after, whichever year you guys are in right now, and you're a doctor. It's the year 2026. You are all doctors. Imagine we all meet 20 years after that, the year 2050, and one of us says, yes, I do on average 15 to 20 chest x-rays on children in a month to look for or exclude the presence or the absence of pneumonia. You will be a doctor who is clearly over radiating your patient. And please remember that x-rays cause radiation, radiation causes oncological disease processes, and we want to try and avoid that. Also do remember that the breast tissue is also going to get affected if you're just doing all these multiple x-rays, and we're going to get young ladies who are going to be budding, etc. And even if you are a male, I wouldn't suggest that you have less chest x-rays done. But we have to be so careful with our girl children not to just go ahead with x-rays. And I'm very, very nervous and uncomfortable, especially when I'm getting pre-pubertal girl children in particular. And we need to really reduce the number of radiation, both to boys, but especially to the young ladies. Next slide.
So these are just a few radiographs showing the various things we've been talking about. This first one here shows the right upper lobe pneumonia. This is lobar pneumonia. Then here you can see bronchopneumonia in the second one. And in the third one, interstitial lung disease, such as in pneumocystis, Giroveshi pneumonia, or CMV.
Go to that first slide. I mean, no, sorry, the first, what is that near the trachea? Is that, do you see that metallic thing in the upper airway? Yeah.
Yeah.
What is that, buddy? Yeah, up there. It doesn't completely look like it's within the trachea, because if you take a look at the trachea is to the left of it as you look at it. But just remember that sometimes, so I think, it just might be an artifact that just, because even next to it, there's something else. So it might be the zipper of a child. Can you see the zip of the child? It looks like a zipper.
Yeah.
When you sent these to me earlier, I didn't really dive into it that much. But colleagues, it's just meant to show you that you need to look hard, because can you imagine if this was a foreign body intratracheal, then this lobar pneumonia is actually a collapse secondary to a foreign body, and what you need to do is then get it out. So that is how in depth you have to sometimes look at these x-rays so that you don't miss anything. If you go to the second slide, the one in the middle, if you look at the trachea there, you'll notice that the trachea is slightly shifted towards the right-hand side. And of course, they have bilateral bronchoalveolar markings that our colleague has shared with us. You can even see the right hemidiaphragm on the other side, Felix, yeah. And then, yeah, you'll notice that you're not able to see the right hemidiaphragm that clearly, like you can see the left hemidiaphragm. So that's indicating that there is also some degree of right lower lobe involvement. If you look at both the heart borders on this X-ray, you'll notice that they are fuzzy on both sides, indicating both right middle lobe and left middle lobe, which is also called the lingula segments as well. And when you take a look higher up, you can see that the disease process is indeed all over. Please remember, dear colleagues, when you're looking at these chest x-rays, also look at the bones, look for signs of metastasis and oncological processes. Look at the bones in this child. When you look at the clavicles, I mean, they look rather osteopenic. So you might want to also look at the vitamin D levels in this particular patient. And when you look at the third slide, I don't have too much more to add. Again, the third slide, the one of ILD, if you look at the right hemidiaphragm, again, you cannot see the right hemidiaphragm as well as that, the left-hand side. And you can see the air bronchograms in this particular chest x-ray, especially the left main stem bronchus and the left lower lobe bronchus going all the way down. You can actually trace it behind the heart. So that's just something that you need to take a look at. And you can see how fine and granular and homogeneous the disease process is bilaterally. So this child must have a lot of VQ imbalances, and CMV and pneumocystis jirovecii gives you significant hypoxemia as part of the disease processes. I think many of you are on the Telegram group, and the beauty of Telegram is that you can go right up to the top and look at all the x-rays. There are hundreds and hundreds of x-rays at an undergrad level that I think would be useful for you to take a look at. Felix, next.
So just other imaging techniques, as has been mentioned, chest X-ray is not always desired, particularly in pediatric populations. So an alternative is ultrasound. And the merits of ultrasound is that it's safe, it has no radiation, unlike chest X-ray, which, as has been mentioned, can predispose to oncological problems later on in life or affect the breast development, particularly in girls. And it's repeatable. Low cost, can be done at the point of care. It's more sensitive than chest X-ray and can correlate with CT, and it also guides procedures. So you can do ultrasound guided procedures. And then another one is CT, but then that's usually only if it's really, really indicated and there's a good reason for doing it.
Carry on.
So other investigations beyond just imaging. So blood cultures, this is not to try and isolate to particularly the organism that you're thinking of, that may be causing the issue. Lung aspirates, bronchoalveolar lavage, throat swabs, and nasopharyngeal aspirates, as well as serology for organisms such as Mycoplasma pneumonia. Okay, now on to management. So this is just straight from the basic pediatric protocol. Yeah, since this one, you can't really skip steps. So I just screenshotted it as it is. So this is for children with pneumonia aged 2 to 59 months without severe acute malnutrition, and also who are not HIV exposed. There's a separate protocol for children with pneumonia and are HIV exposed, and we'll look at that very briefly towards the end as we conclude. So if there's a history of cough or difficulty of breathing in a child who's more than 60 days, and they have one of the danger signs being oxygen saturation of less than 90%, central cyanosis, inability to drink or breastfeed, AVPU less than A, so they're not alert, and grunting. So if yes, that is severe pneumonia as we classified before, and so you need to admit, or you refer, if at all you're in a lower CADA facility that cannot handle such a case, and then give oxygen as required, IV penicillin and gentamicin, then continue monitoring using so SpO2 and also supportive care.
Carry on.
Then if there are no danger signs, then you have lower chest wall indrawing or fast breathing. So the breathing is usually age dependent. So the categorization depends on age. So more than 50 breaths per minute. If the rest rate more than 50, if 2 to 11 months, for more than 40, 12 to 59 months, yes, that's classified as pneumonia or non-severe pneumonia. And in this case, you give high dose amoxicillin, dispersible tablet, 40 to 45 milligrams per kg per dose, 12 hourly. And you consult carefully on danger signs and the need to return if any of the danger signs we mentioned previously develop. And all children must be reviewed within 48 hours. And if the review is not possible, then admit the any children with indrawing, lower chest wall indrawing. And then if it's no, also for the lower chest wall indrawing and fast breathing, then that is no pneumonia. So that's like just a cough or a cold, of which you just reassure and counsel on the danger signs that the parent should be or the guardian should be looking out for. And if there is a wheeze, you should consider the possibility of this being asthma or an alternative diagnosis and treat according to separate protocol.
And the last point is how we started today's initial slides for those who might have joined a bit later, which is that if you have crackles and wheezes, you could have lung pipe pathology, bronchiolitis, bronchitis, cystic fibrosis, cow milk allergy, aspiration syndrome. Take note of those differentials, please. It would be something important to write down. But if you have crackles on its own, then you need to start thinking about lower airway. But if you have wheezes, you need to think about the pipework being affected. And like we agreed earlier, pneumonia is not a disease of the pipes. It's a disease of the parenchyma. Felix?
So there's pneumonia treatment failure, and there are various definitions according to the basic pediatric protocol. And in this, first and foremost, before you even consider that it's treatment failure, you need to ensure if there is HIV infection or TB, that may underlie treatment failure, and testing is important for that child because you may be treating the wrong thing, because in HIV, pneumocystis is a key player in pneumonia, and TB has a specific protocol of its own, which I guess will be covered on a different day, which treat with anti-TB drugs. So how treatment failure is defined. So it's anytime you have progression of pneumonia to severe pneumonia. And severe pneumonia, in this case, is how we defined it: development of cyanosis or inability to drink in a child with pneumonia without these signs on admission. And then obvious cavitation on chest X-ray. And what do? The action required is that you admit the child, you change the treatment from amoxicillin to, which was the oral tablet we discussed, to now the IV antibiotic for antibiotics for severe pneumonia, which are penicillin and gentamicin. And then you treat with flucloxacillin and gentamicin intravenously for Staph aureus or gram-negative pneumonia. And that we mentioned prior is particularly in hospital-acquired pneumonia. That's why we have Staph aureus and gram-negative organisms playing a part. And in that case, you treat with flucloxacillin. Then that one was for any time, and then 48 hours. So 48 hours have elapsed. So severe pneumonia in a child getting worse. So reassess thoroughly and get chest X-ray if not done. So you need to get a chest X-ray looking for empyema, effusion, cavitation, etc. So pneumonia without improvement in at least one of the respiratory rate, severity of indrawing, fever, and inability to drink or feed. So if you're treating and the severe pneumonia, but it's not improving after 48 hours, you'd now want to consider that maybe there is resistance. And as Joshua mentioned, you'd now want to change your antibiotic and upgrade. So you switch to ceftriaxone unless you suspect staphylococcal pneumonia, in which case now you use flucloxacillin, which are these, the penicillins that have anti-staphylococcal effects, and gentamicin. And then if you suspect pneumocystis pneumonia, especially if less than 12 months, an HIV test must be done and you treat for pneumocystis if they are HIV positive. And then admit the child and then change treatment from amoxicillin to penicillin and gentamicin.
Carry on.
Day 5, so at least 3 of fever, temperature more than 38 degrees, respiratory rate more than 60, then still cyanosed or saturation less than 90%, and no better than admission, chest indrawing persistent and worsening, chest X-ray. So if only on amoxicillin, you need to admit the child and change to penicillin and gentamicin. And then if on penicillin and gentamicin, you need to upgrade, move on to ceftriaxone. And then if you suspect pneumocystis pneumonia, again, an HIV test must be done, and then you treat for pneumocystis if HIV is HIV positive. And then if the cough lasts more than 14 days, so you have persistent fever and respiratory distress, you need to consider TB. Perform a MAN2 test, a chest X-ray, and check TB treatment guidelines for the appropriate management in that case.
Carry on.
So for pneumonia in HIV-infected children, as we mentioned, so it has a different protocol. So all HIV-exposed or infected children admitted with signs of severe pneumonia are treated with penicillin and gentamicin first line. Ceftriaxone is reserved as second line therapy. And second, high dose cotrimoxazole if aged less than 5 years for treatment of pneumocystis pneumonia. And steroids are not recommended for PCP. That's pneumocystis pneumonia. So treat and prevent pneumocystis pneumonia with cotrimoxazole. And then this is how it's dosed. We can always just have a look. It's weight-based, and then there's a syrup, tablets, tabs, so 240, the different formulations.
Let that go.
Yeah.
Colleagues can read that at
Yeah.
pleasure later.
Yeah. So we mentioned supportive therapy in the protocol. And so what supportive therapy entails is oxygen, and then ventilation. So oxygen, so if the saturations are less than 90%, and then ventilation, which
I'll
can
stop you.
Yeah.
So I think, colleagues, this slide is probably clear. Oxygen, ventilation, bronchodilators, colleagues, by the time you're using a bronchodilator, you really, and because of significant wheeze, you really have to start questioning your diagnosis at this time. Because at this point in time, you put the child on standard antibiotics, you're probably moving to second line, the child is wheezing. You've most likely got the diagnosis wrong, and it's most likely an acute asthmatic attack. Excuse me. I think when it comes to hydration monitoring and suctioning, I think we are all clear about that. Don't forget the role of elemental zinc, colleagues. This is something I forgot to mention to Felix, that in immunosuppressed children or children who are severely malnourished, administration of elemental zinc, usually around 10 to 20 milligrams per kilo, given once daily, has been shown to help with the re-epithelialization of the bronchial lumen. And that helps in healing, along with other immunomodulatory effects. Next slide, Felix. We're also cognizant of time now.
Yeah, so this is the last slide on prevention of pneumonia, and this is just a summary of if you want a more detailed explanation is in the child health seminar we had, and this is the integrated global action plan for prevention of pneumonia, prevention and control of pneumonia and diarrhea. So the two conditions are combined. Initially, it was just focusing on pneumonia, but after evaluation, pneumonia and diarrhea were put together because they have the same drivers and often they coexist and they need to be tackled together. So, and the pillars are to protect, prevent, and also to treat. So, just to as a summary, so to protect children by establishing good health practices from birth, and then there are the specific things that you do when it comes to protecting breastfeeding, exclusive breastfeeding, adequate complementary feeding, and supplementing.
Felix,
Yes.
I'll stop you there. I think colleagues can read this. I think it's pretty self-explanatory after what we've gone through. Is this your last slide, Felix?
It is.
Okay, colleagues, you haven't posted any questions. It's the time to unmute, ask a question. If you're silent, I'm silent. Remember, we talked about RSV vaccination. It'll be a very, very important topic to read because that vaccine is going to come in our time. And for the influenza vaccine, there's a quadrivalent variety that has been registered as of this year. So hopefully that will increase its efficacies from the trivalent that was being used earlier. Remember that the influenza vaccine has both an intranasal spray variety, not available in Kenya, and the injectable variety available in Kenya, but it has to be given every year. Questions from the team?
Hello, I have a question.
Go for it.
John. Yes. So when we are looking at the microbiota that is within the upper respiratory system, we saw like rhinovirus was a commensal, yeah. But among the top 10 causes of pneumonia, rhinovirus is one of them. So I was wondering, is it even when it's a commensal, how does it still be pathological? Yeah.
Excellent question. So imagine you have, I'll just talk basic. Imagine you just have two rhinoviruses that are sitting in your lower airway. Then you get invaded by some severe RSV that then invades, the lower airways and disrupts the whole area. Now that disruption can sometimes allow the human rhinovirus to now super multiply because that whole area is now devastated. There's cytokines all over the place. There's alveolar edema, there's epithelial cell degeneration and denudation, etc. So it's, these guys are all sitting in our airways, happy, waiting for somebody to rock the boat, and then they start overgrowing, multiplying, and causing localized damage. Does that make sense, John?
Yes, it makes sense.
Okay.
Thank you.
Another question, colleagues?
Hello.
Yeah, go Fiona.
So my question is, from the discussion that we've had, is it your opinion that antitussives or rather cough suppressants should be completely phased out of the market because they have no role in helping patients who have developed a cough whatsoever?
Fiona, you've touched my pet topic. And that is what I've been beating drums about. The WHO in 2003, 2004, Fiona, stated that all mucolytics, antitussives, the chlorpheniramines, the dextromethorphans, the codeines, the bromhexines, the ambroxols, the carbocysteines, these are all ingredients that are found in various cough mixtures that none of them actually have therapeutic doses. Think about this, Fiona. You have a 3-year-old child in front of you, you're giving 5 mLs of a syrup 3 times in a day, and that 5 mLs is supposed to have an antitussive, an antimucolytic. There's just not enough space in that teaspoon for you to give effective medication. So these medications, like the rhinathiol with the promethazine has been shown to cause apnea and death in children under the age of 2 years. And that rhinathiol with promethazine is made in France, not sold in the European Union, but is happily available for Black Africa and Brown Asia. Now, that's a very, very sorry statement, that you're not happy to sell it to some white children in Europe and America, where it's banned, but you're happy to dump it on sub-Saharan Africa. And, Fiona, I know that's a very strong statement, but it's the truth.
Yes.
The textbooks of pediatrics, the textbooks of pharmacology, none of them talk about the role of cough mixtures for either the common cold, or for bronchitis, or bronchiolitis, or asthma. And I need you to know, Fiona, that I've never prescribed a cough mixture in my life, ever.
Okay.
And so I strongly urge you, young people, the drug pharma industry is waiting for you guys. And they're waiting to corrupt you. Right now, you're all young and full of integrity. But that money and dollar will be wagged into your face, and that's when you must not fall, dear colleagues. We must all stand united. Antitussives, cough suppressants, etc. are not indicated for any type of cough because they do not work, period. And they have potential side effects. 123 Gambian children died last year from cough mixtures, and 100 and something Indonesian children died last year and this year from cough mixtures. There was also the Benylin recall from Kenya 4 or 5 months ago for reasons of toxicity. So this is a reality that we have to deal with. We are in a corrupt environment, and I think you understand what I'm saying. And so we are fighting corruption. And when you're fighting corruption, it's a lonely war. But when you have young people by your side, it's never lonely.
All right, thank you.
Next question, colleagues. And the same, Fiona, applies to antihistamines as well. Antihistamines are useless for bronchitis, bronchiolitis, the common cough and cold. In fact, Felix, one day we must do the common cough and cold. Sometimes the most basic of things is hardest to treat. So antihistamines also fall into that realm. Next question, anybody?
Hi.
Go for it.
Yeah, so from the patch study, we saw that the top 5 causes of pneumonia are viruses.
Correct.
But according to our protocol, I realized we basically give antibiotics for bacteria. So is there a role for antiviral medication in the management of pneumonia?
Wonderful question. That's the best question so far. But listen, there's no antiviral. That's where we are stuck. I don't have an anti-human metapneumovirus, etc. When there's something called oseltamivir, which is Tamiflu for the treatment of influenza. But even for the treatment of influenza, the oseltamivir is only useful if you get the patient come to you within the first 48 hours of disease. And most patients will not come to you. And it's also a very expensive drug. And how our health-seeking behavior in this country, we mustn't start talking about Karen and Lavington. This world is not about Karen and Lavington. This world is about what's happening in Garissa and Bungoma. And the health-seeking behavior is such that the mums are going to come on day 4 or day 5. And at that point in time, a lot of these antivirals do not work and are not available. There is nesirvimab and monoclonal antibodies used for the treatment of RSV, prevention and treatment of RSV. But again, their injections, they cost about 100,000 shillings. And I think you're read beyond that point. So I believe 10 to 20 years from today, we will understand that the reason oral amoxicillin is actually helping a lot of our patients is because we are treating a viral infection with an amoxicillin. And it's not because the virus is sensitive to amoxicillin. It's just that viremia, that viral pneumonia that the child has, which is what is the main diagnosis, is actually a self-limiting condition, and all you need to do is give IV fluids and oxygen and paracetamol. But you see, dear colleagues, you and I can't know who's the one who has strep pneumonia and who's the one who has RSV. And you and I cannot be found guilty of killing a child by withholding a penicillin. So I believe that oral amoxicillin is working for a large number of our patients because we are not even treating the strep pneumonia, and it's just a self-limiting viral LRTI. I love your question. Next question. Are we done? Felix, tumechoka?
I have a question.
Go for it.
Now that the antihistamines are contraindicated in common cold, what do
Yes.
we use?
Saline nose drops, Vincent, honey, and saltwater gargling, which is what I do when I'm unwell. I have never taken an antihistamine for a common cold, FYI. I refuse to violate my body with an antihistamine when nasal secretion histamine levels are not raised with the common cold. Because when you have the common cold, mast cells are not degranulating in your nasal epithelium. The fluid in the nose is not because a mast cell has degranulated. The fluid in the nose is because the blood vessels have dilated, and that is what you're getting. So antihistamines do not work, and I'm not quoting Dr. Waris, I'm quoting the WHO. I'm quoting systemic meta-analyses on the same topic.
Okay, thank you.
Yes, John Waniki, Flugon to the garbage can. John, I promise you, I have never prescribed Flugon to anybody in my life in the past 20 years. Last question. We're good, guys? Sawa. Felix? Okay, Esther. What? It was Esther. I got in late. Roll of steroids. 0, Esther. Steroids are not used for pneumonia. I think we'll stop there. We've done 1.5 hours. Felix, you and your team will reach out to me, and we'll see if there's a possibility of us doing another one before Christmas next week. Sawa?
Yes, that's okay.
All right. You guys have a good day. Good evening.
Thank you.